I guess. Uh, Free paper session here with the proximal humerus as the main topic, around proximal humerus, I would rather say. So the first topic is a study of association between acromion types and shoulder pathology by Dr. Sagar Venkataraman. It can be started now.
Good morning. Today's the topic for the abstract which I have submitted is study of association between acromion types and shoulder pathology. I myself is Dr. Sagar Venkatraman, and abstract ID is OASP 223 and registration ID is OASV 403. Introduction. So shoulder joint is one of the important joint in the human body. Shoulder joint is complex and mobile joint. Acromion process is the important structure around the shoulder. Shoulder impingement and shoulder rotator cuff tear are commonly seen in shoulder pathology. Pathological changes can be due to the intrinsic degenerative in tendons or extrinsic mechanical compression due to the acromion types. Supraspinatus tendon lies beneath the inferior border of
There's some
acromion.
audio issue.
Changes of the acromion
Yeah,
morphology
not
or tendon
very
that might be
loud enough.
one of the cause for the impingement syndrome and the rotator cuff tear. The part of the acromion process which is in contact with the rotator cuff tendon produces friction during the shoulder
I
abduction or
think person from
rotation and
WebCon
damage
events can
that
sort out
rotator cuff
this. The
damage to the
audio
tendon.
is
Viglani was the first
So is
person
the
to
not
audio
clear.
describe
very
the
low?
acromion
Are
Yeah,
you
it is
unable to
very
hear?
low. Yeah,
Okay,
it
let
is.
me
so
get
the
Yeah,
that
you
primary
are.
sorted.
objective was to determine the acromion types, its prevalence and
Yeah, we can
etiology,
hear, but
and
this
second
audio
objective
of
was
this
to find the
recorded speech is
correlation
very
between the
poor.
Sure, sir,
acromion
I'll get that
morphology
checked.
and the age group. So in this materials and methods, we this was a prospective study design which started from the year January 2019 and it in December
Maybe the
2019.
presentation itself
Around
is
total
like that.
85 patients who met
This is a
including 3
pre-recorded
included in the
presentation,
study.
so I
Yeah,
think
yeah.
Detailed
that
clinical
that time only the
information
audio
workup
is.
was done for the patient diagnosed with shoulder impingement syndrome or rotator cuff tear. Radiographs like supraspinatus outlet view and shoulder anteroposterior view was taken. So acromion types were classified according to the Biglani et al. Type 1 acromion which showed flat undersurface, type 2 acromion which showed curved undersurface, and type 3 acromion which showed hooked undersurface on supraspinatus outlet view radiographs. Types of acromion was classified again based on a radiograph and was correlated with the shoulder pathology and age group. So our inclusion criteria was patient of age more than 20 years and
So we
patients
are
with
trying
uncontrolled
to
impingement
increase the
syndrome or
volume, though
rotator cuff
it's a
tear
recorded session and volume
included
is
in our
pretty low
study.
from
In
the session
exclusion
itself.
criteria, those patients who
All the
had
talks are going to
traumatic
be
shoulder
like this, or
pathology, patients
this
who had
particular one?
Actually, not.
fractures
We have tested a couple of talks which had
shoulder,
proper audio.
and
So
patient
probably
who
this
had
one has a little bit of
reconstructive
an issue.
shoulder pathology
Okay, we'll
SPM
wait for the
syndrome,
next one. How it?
Sure,
and
doctor.
all these
Yeah.
patients were excluded from our study. Here you can see the
It's very
first
low
figure
that
is
it
the
is
flat
not
type of
audible at all.
acromion which was classified on the type 1, and here in second figure you can see the acromion was curved and it was classified in type 2, and here you can see the undersurface of the acromion was hook shape and it was categorized under type 3. These all three were
Even
based
at the
on
recording
rotated
stage, this
radiographs of the shoulder.
presentation was not
Coming
put
to
in the
the
slideshow
results,
mode.
the age of the patient, which included less than 51 years, was 43. More than 51 was 42 patients, and among the male patients were 50, and female patients were 35. Affected side left was seen in 39 patients, and right sided was seen in 46 patients. Among this, left sided dominant was 29, more right sided dominance was seen in this patient, and diagnosis impingement syndrome 43 patients were included, rotator cuff tear 42 patients were included. Among this, overall type 1 acromion constituted around 20, and type 2 which constituted around 55 patients, and type 3 acromion was seen in 10 patients. And based on group 1 we categorized as impingement syndrome, group 2 we categorized included rotator cuff tear. So type 1 acromion was seen in 12 patients, that is in group 1, and type 1 acromion was seen in 8 patients, that is in group 2, that is rotator cuff tear. Type 2, 27 patients seen in case of impingement syndrome, whereas type 2 acromion was seen in 28 cases in rotator cuff tear. And type 3 seen in 4 patients in impingement syndrome, and type 3 acromion was seen in 6 patients among the rotator cuff tear. So here you can see among the types, type 2 was more common in both the groups. Association, when we consider the secondary objective, that is the association between age and the acromion type. Here you can see less than age 51 years. Again, type 2 was more common, and more than 51 years also type 2 was more common. And as you can see, type 2 was more common in both age groups. Coming to the discussion part, in the shoulder impingement syndrome group, type 1 acromion was seen in 27.9 patients, type 2 acromion 62.8%, and type 3 acromion was seen in 93% and 9.3 patients. And in rotator cuff tear, group 1, type 1 acromion was seen in 19%, type 2 acromion was seen in 66.7%, and type 3 acromion was seen in 14.3%. Our results were compared with Balke et al., Parvaske et al., Gates et al., Nicholson et al., where in all this study demonstrated that type 2 acromion was more common. And in our study population also, we found that type 1 acromion was accounted 23.5% and type 2 acromion was 64.7%. And overall, type 2 acromion was more common. So, Balke et al. Study reported that mean age group for impingement syndrome was 49 years, for rotatic cuff tear was 60 years. Our study, wherein impingement syndrome was 39.6 years, whereas rotator cuff tear was seen in 58.6. So, impingement syndrome was more common in younger compared to the degenerative rotator cuff tear, which was seen in older age group. Our study results also showed there was no correlation between the acromion type and age. Few of the studies showed that as the age advances, the type 1 gets converted into type 2, and later on type 2 gets converted into type 3. But in few of the literature also showed that as the age advances, the type of the acromion remains same, and it is not that is acromion type is not correlating with the as the age advances. Around 53.5% of study population aged less than 51 years had type 2 acromion, and 76.2% of study population aged was more than 51 years had type 2 acromion. However, this association was not statistically significant. The percentage of type 3 acromion in patients more than 50 years was less, which again showed that there is no correlation between acromion type and the age. That is, as the age advances, even the type of acromion also remains throughout the as the age advances, the acromion type remains same and it will not get converted into the type 3. Okay. Our results compared with the studies at Case et al., Nicholson et al., Vickery et al. In this all studies showed that there is no correlation between acromion type and the age. So, based on this findings, we conclude that type 2 acromion was more frequently seen in the shoulder pathology. And as the literature said that type 3, because of hook shape of acromion, the degenerative change, rotator cuff tear, as well as impingement syndrome it can cause. But in our study, based more than type 3, type 2 acromion was more commonly seen in this shoulder pathology. And even acromion morphology also, some studies has proven that as the age advances, again the acromion morphology also varies. It is get converted from type 2 to type 3. But from our studies, it proves that both the age group less than 51 years and more than 51 years also, there was more type 2 acromion only. This proves that as the age advances, the type of acromion morphology doesn't vary with the age. Okay, thank you.
Okay. So thank you for the good paper on acromion Dr. Sagar Venkatraman. Any questions, Dr. Janardhan? Is there any question on the, you can look into that?
I don't see any questions in the chat box.
We have about 1 minute, I think, because we fell short of 1 minute by presentation itself. So
I just want to ask one question if the speaker is here.
Yes, sir.
he's there, he's there.
Yes, sir.
Yeah. So you are telling that type 2 acromion is common in patients presenting with shoulder impingement. Any idea what is the general scenario in normal people? Like what type of acromion is common among the normal population who do not have any shoulder pathology?
Yes, sir. Actually, we didn't compare with the normal population, sir. So we
So
identified only the disease like
disease,
either
yeah, correct. So
correct.
because to know, to
So we
say
didn't had
that
a
the
control group.
type 2 is more commonly associated with shoulder pathologies,
Yes, sir.
you need to look at the picture from the normal population
Normal
also.
population. Yes, sir.
Yeah, suppose
Yes.
it may be possible that type 2 acromion may be the commonest among all,
Okay, sir.
and hence you see more patients with the type 2 acromion.
Okay, sir.
Yeah, I think they have done, the patient selection is only with the complaints. They have not done general screening or, isn't it? Yeah,
Yes, sir.
that would be a good study if you look into the general population, what types of acromion prevails.
Okay.
And you may get good idea whether the age has also an implication there, because
Okay, sir.
here you're looking into the subjective patients with complaints, isn't it?
Yes, sir.
So if there are no question, can we move on to the second speaker?
Yes, we'll go to the second speaker.
Yeah. Comparative study of efficacy of platelet-rich plasma injection and corticosteroid injection for periarthritis of shoulder. Again, from Dr. Adarsh Krishna, I think he's already there. You can start the talk.
Good afternoon. I'm Dr. Adarsh Krishna Kebut, Senior Resident, Department of Orthopedics, Government Medical College, Kottayam, Kerala. And I'm going to present the topic, comparative study of efficacy of platelet-rich plasma injection and corticosteroid injection for periarthritis shoulder.
The web
Moving on to the
master,
introduction.
can it be
Periarthritis
in the
shoulder is also known as
slideshow mode?
capsulitis of frozen shoulder. Frozen shoulder is a disease that causes significant morbidity. The term frozen shoulder was first described in 1934 by Carl.
Recorded video.
Adhesive capsulitis is a
we
painful
wanted
and disabling
slideshow
of
mode.
unclear cause in which the shoulder capsule,
Already
the connective tissue
recorded.
surrounding the glenohumeral joint of the shoulder becomes
Already
inflamed and
recorded.
stiff, greatly restricting motion and chronic pain. The annual incidence of periarthritis shoulder is around 3 to 5% in the general population and is as high as 20% among individuals with diabetes. It usually develops between the ages of 40 to 70 years, and risk factors for frozen shoulder include diabetes mellitus, stroke, accidents, lung disease, malignancies, thyroid disorders, and heart disease. The condition tends to be self-limiting and usually resolves over time without surgery. Most people regain about 90% of the shoulder motion over time. Moving on to the aims and objectives of this study, to compare the outcome of local autologous platelet-rich plasma injection and local triamcinolone injection in patients with periarthritis shoulder in terms of pain and range of motion. The study design included 30 patients in each group. That is, Group A was triamcinolone injection and Group B was autologous PRP injection, who received treatment at Government Medical College, Kottayam during the period March 2018 to March 2019, and they were followed up during the first, third, and sixth week, and were assessed using visual analog scale and range of movements. Further statistics and inference was drawn upon. Coming to the sampling method, two groups were formed, with Group A receiving local triamcinolone injection and Group B receiving autologous platelet-rich plasma. A 24-gauge 1.5-inch needle was inserted medial to the head of the humerus, lateral to the coracoid process by 1 centimeter, and was directed posteriorly at a slight superior and lateral angle. The needle should slip into the joint completely and the injection have no resistance. After negative aspiration, a 2 ml mixture of 40 mg of triamcinolone acetonide and local anesthetic 2% lignocaine is injected, and this is for the Group A. Coming to the Group B, PRP preparation and injection, the American Association of Blood Banks technical manual states that platelet-rich plasma is separated from whole blood by light spin centrifugation, and subsequently platelets are concentrated by heavy spin centrifugation with removal of the supernatant plasma. So under aseptic precautions, 18 ml of blood is drawn from the subjects belonging to the Group B via venipuncture using a 22-gauge needle and mixed with 2 ml of anticoagulant citrate phosphate dextrose in the sterile test tube. It is centrifuged at 1500 rpm for 10 minutes, and further it was again centrifuged at 2500 rpm for 10 minutes. Approximately three-fourths of supernatant is discarded and the platelet-rich pellet is resuspended in remaining amount of plasma. This PRP sample is injected into the affected shoulder by anterior approach, which was then dressed. This is the presentation slide showing the visual analog scale in which there's a line and an X is supposed to mark in the line, wherein the least score had no pain and highest score is pain as bad as it could possibly be. And based on this, it was categorized into between 1 to 10. So inclusion criteria of my paper included age 40 to 70 years, shoulder pain for at least 1 month, with the gross almost one-third loss of motions of the shoulder, normal AP radiograph of the glenohumeral joint, and patient with USG confirmed periarthritis shoulder. Exclusion criteria included intrinsic glenohumeral pathology, history of shoulder trauma or surgery, history of previous injection in the preceding 6 months, and patients having significant comorbidities. Coming to my observations and results, the age incidence, the mean age was around 55.7 in group A and 53.4 in group B. Coming to the gender, majority of them were males in case of group A and majority of them were females in case of group B. Coming to the side, majority of them were right-sided in group A, and when it comes to the group B, almost it was 50-50. Coming to the diabetes distribution, as I had already mentioned, that diabetes people with diabetes have a higher risk to get periarthritis shoulder in group A as well as group B. Majority of them were diabetic. Coming to the age distribution and occupation, based on that, as you can see in this graph, the sedentary occupation, people who are leading a sedentary lifestyle at a higher risk compared to that of the heavy manual laborer and the manual laborer. And similarly, the age group of 40 to 50 had considerably little bit of a higher risk compared to the other age groups. Coming to the range of measurements in baseline, as you can see, flexion, abduction, internal rotation, and external rotation were grossly restricted in case of periarthritis shoulder in both the case of group A as well as group B. Coming to the RO measurements at 1 week between the groups, you can see that there is some amount of improvement compared to that of pre-baseline values in both as well group A as well as group B in flexion, abduction, internal rotation, and external rotation. Coming to the third week, again we can see the improvement is much more compared to that of the first week in both in case of group A and group B. But if you look closely, you can see that the group B values are somewhat better than that of group A by a small margin. Come to the group 6 RO measurement at a 6th week, similar again like the third week and the first week, the improvement is more in case of group B rather than group A by a small margin. Coming to the VAS measurements, that is visual analog scale measurements, you can see again compared to the previous, that is the pre-injection era and then first third week, you can see the pain is considerably decreased, and the decrease is quite by some margin more in case of group B rather than group A. RO measurements at first week, third week, and 6th week in group A, as you can see, all the movements, that is flexion, abduction, internal rotation, and external rotation, were improved in case of post-injection periods, that is first week, third week, and 6th week, and similar values can be seen in group B as well. But in comparing between group A and group B, I think it's quite evident that the values in group B are quite better compared to group A. Compared to the visual analog scale comparison, you can see that post first week, post third week, and post week, the pain is decreased. But in group B, the values are better. That is, the pain has decreased better in case of group B. So coming to the conclusion of the study, in this study, it was found that both platelet-rich plasma injection and local transfusion injection resulted in pain relief, and the mean decrease in visual analog score was more in case of platelet-rich plasma group compared to the steroid group, and it was statistically significant. This study has also found out that both platelet-rich plasma injection and local transfusion injection resulted in functional improvement in patients, but the mean increase in range of motion, as flexion, abduction, internal rotation, and external rotation, was more in case of plasma-rich platelet group compared to steroid group, and it was statistically significant. So I would like to conclude saying that in this so the limitations of the study, the outcome measurement VAS used in the study was more of a subjective thing than the objective, and it is used to measure pain, which is a subjective symptom also as well. The VAS score is not specific for periarthritis shoulder. The effectiveness of PRP at different stages of periarthritis shoulder is not studied. For complete assessment of efficacy of treatments, patients have to be followed up over a longer time. A large and double-blinded controlled clinical trial would be desirable. So these are some of the comparison with other literatures. Some studies are shown by Shashanki Yashwant Kothari, who studied 195 subjects, also proves the PRP efficacy. Zhang et al. Had a reported widespread application of PRP in various musculoskeletal injuries, which also proved the efficacy of PRP injections. Giotis et al. Studied effectiveness of PRP in other biologicals, and he also had a promising result. And similar reports also by T. Muto and T. Kobuko reported the combination of triamcinolone and PRP, which exerts an anti-inflammatory and degenerative effect on rotator cuff injuries. These are my references. Thank you.
So thank you for a good presentation on PRP versus triamcinolone injection for periarthritis and impingement of shoulder. Uh, Dr. Janardhan, any questions from the audience? No. Yeah, I just wanted to know.
There are no open questions.
Yeah, I have a question to the presenter. He's around, I think.
Yes, sir. Yes, I'm there, sir.
Yeah, one is, my opinion, we did a study, similar study. I think ultrasound guided injection is much better than what you have advocated here, because you're not very sure, because your aim is to get into the joint, correct?
Yes, sir. Yes, sir.
So there are a lot of fallacies in blind method, what you have adopted. And what type of PRP, double spin or single spin you have?
A double spin, sir.
Okay. Dr. Janardhan, you have any question for the presenter?
No questions.
Okay, you can announce the next speaker, Janardhan.
Yes.
Thank you, sir.
Yeah,
Thank you, sir.
one moment. Once the presentation is finished, I request the presenters to start their video, only the presenter, so that they can answer any questions if asked by the moderator.
They should come on the screen. What do you
They
mean?
should come on the screen and unmute themselves. Yes.
Unmute themselves, and after their presentation.
So we'll go to the next presentation, graft augmented osteosynthesis of proximal humerus fractures in osteoporotic patients by Dr. Ravi GR. Dr. Ravi is here?
Yeah, he is here. He can start his presentation.
Okay, right.
Yeah, it's pre-recorded.
It's pre-recorded. The host can start.
Dr. Ravi GR, my oral presentation topic is graft augmented osteosynthesis of proximal humerus fractures in osteoporotic patients. Coming to type of study, this study is a clinical, prospective and observational study conducted at KR Hospital MMCRI, Mysore on 20 patients who are osteoporotic with proximal humerus fractures. Coming to materials and methods, in the period between June 2019 to May 2020, 20 patients underwent graft augmented osteosynthesis of proximal humerus fracture in osteoporotic patients after taking an informed consent. Inclusion criteria for my study is age more than 45 years, T-score less than minus 1.0, osteopenic or osteoporosis according to DEXA bone densitometry, and patient undergoing revision surgery for failure of other implants, and Gustilo-Anderson type 1 open fractures is also studied here. Exclusion criteria for my study is pathological fractures from primary or metastatic tumors, patient's age less than 45 years, Gustilo-Anderson open type 2 and type 3, polytrauma patients, and failure of conservative treatment, fracture with associated dislocation or neurovascular complications. 20 patients who underwent graft augmented osteosynthesis of proximal humerus fracture in osteoporotic patients had radiological and functional follow-up for up to 6 months. Follow-up is done with X-rays and functional assessment. X-rays has been taken with 15-degree external rotation and slight abduction, and the X-rays which was taken was measured with neck shaft angle. Outcomes assessed by visual analog score for pain, constant and Mully scoring for functional outcome, and neck shaft angle in X-rays taken. These are the surgical and radiological images of the following study. Here we are undergone with the delta anterolateral approach. This is the site of graft harvest. It is taken preferably in the operated side of the leg. About 4 to 5 centimeter of fibular stud graft is taken and harvested aseptically, and the stud is passed from the fracture site and malleted slowly into the intramedullary canal, and reduction is achieved after inserting the graft. Then Philos plate of adequate size is chosen. Mainly for 4 to 5 old Philos plate is chosen for the proximal fixation. These are the images taken in CM for adequate reduction and proper placement of fibular stud graft. This is X-ray of a post-op case with a good reduction, and you can see the fibular stud graft which has been placed at the junction of the neck and shaft junction. This is a comparative image of the X-ray and reference article image of our patient and the reference article image of the article. These are a table of data and functional outcomes of the participants of my study. Among 20, mean VAS score is 2.2, and range of motion we got for forward elevation is 148 degree. External rotation can be up to 58 to 59 degrees. A mean degree of neck shaft angle difference is 1 to 2 degrees. Results: the mean fracture healing is 18 weeks, and the average constant and Murley score we got is 90 points out of 100. Superficial infection was found in 2 patients, stiffness in 1 patient, and a change in neck shaft angle was found in 2 patients with minimal change of 1 degree. Brief literature. Fracture of the proximal humerus represent approximately 4% of all fractures and 26% of humerus fractures. A locking plate is currently the most widely used method of fixation for these fractures in both young and elderly patients. There is a high chance of implant failure in osteoporotic patients with only Philos plate fixation. So the use of locking plate along with intramedullary autograft is an established technique for these fractures, particularly in osteoporotic patients. Our study aimed is to assess the functional and radiological outcome of proximal humerus fracture, which is managed with Philos plate along with graft and followed them prospectively. Conclusion of my study is graft augmented osteosynthesis provides good bone healing and decreases varus collapse and screw lagout with near normal anatomy like normal range neck shaft angle and a good functional outcome and radiological outcome. Thank you.
Good paper, Dr. Ravi. I just wanted to know what is the range of movements that you got after this procedure?
Sir,
Ravi, you can start your video.
Okay, sir.
Yeah, you can switch on your video as well as
Video, and you can answer.
So video I'm not able to switch off. Sir.
Okay, no
There's some
problem.
problem.
No problem.
No problem.
Go on.
Sir, and I was started mobilizing after 3 weeks, sir. Anti flexion and little bit of abduction started with passive movement, sir. After 6 months of follow up, I got around. Hello.
yeah.
Hello.
Yes, we can hear you.
After 6 months of follow up of my study, sir, there is a flexion of 148 to 151 degree, 150, and in anterior flexion, and external rotation up to 50 to 58 degree I got, sir. And abduction, overhead abduction, the one patient had some little difficulty, sir. But overhead abduction, hello.
Yeah. I think
Some audio issues.
yeah, some audio issues there. Can you hear us, presenter?
Yes, sir. Yes, sir.
Yeah. Now, you have done this for all types, or only have you selectively included types of knee fracture?
2-part and 3-part fracture, sir. 4th part there is associated with some dislocation, sir. So it is chances of AVN or osteoarthritic changes were there, sir. Hence, started with 2-part and 3-part fracture, sir.
How many of them are 2-part and 3-part? Because I don't think there is any need for bone grafting in 2-part fracture at all. So what was the?
Sir, if there is some varus collapse, I would consider it for grafting, sir. If there is some varus collapse, because
have you considered a combination on the medial aspect as a criteria?
Yes,
Yeah,
sir.
something.
Yes, sir. Loss of posterior medial
Or
calcar of
all
femur.
patients with the type 2 and type 3 you have done this procedure?
I've done DEXA scan, sir. If the patient is comes under osteoporotic range less than 1.0, then we have advised the patient to get it along with fibula stud graft, sir. So the
Okay,
varus
so
collapse and
irrespective of the combination, depending upon your
yes, sir.
DEXA scan report, you have done this procedure.
Yes, sir. Yes, sir. For surgical neck fractures, sir.
You had
Yes.
two infections, superficial infection. What did you mean? They just settled by themselves, or you had complications out of that?
Among the two, initially there was some this one, sir, gaping was there, sir. And
Because
after local
with the less number of cases, you have two infection means that means you have a significant percentage of infection which is not seen in proximal humerus fracture in general scenario. So was it because of your grafting, your additional time you took for the surgery and additional exposure that must have been?
not because of grafting, sir, probably, but that the infection has cleared, sir. Now, we initially during that 12 days period, there was some gaping, sir. Hence, we have advised for some local mupirocin along with some IR antibody we did, sir. Now there is no sinus discharging sinus.
Fine then. We will move on to the next. Dr. Janardhan, you can announce the next speaker.
The next talk will be on a prospective study of functional outcome of proximal humerus interlocking system plating for displaced proximal humerus fractures. Dr. Manjunath R.
Good morning, sir. Today my paper presentation topic is a prospective study of functional outcome of proximal humerus interlocking system plating for the displaced proximal humerus fracture. Introduction. Fracture of proximal humerus fracture of proximal humerus account for 4% of all fracture and 80% of the humerus fracture. Most commonly seen in the elderly patient due to the osteoporotic quality of bone, and less commonly seen in young patient because of high energy trauma. And most of the fractures are undisplaced. Around 85% of minimally displaced and 15% are displaced. The treatment it is a challenging for the treating orthopedician. Treatment modality includes conservative and surgical method. The management depends on the displacement and angulation of the fracture fragment. Pillows plate provides a rigid fixation and more angular stability and early mobilization. Aim of the study: to study the functional outcome of Pillows plating for the displaced proximal humerus fracture by using constant modulus score. The method: a study design is a prospective study and study period May 2019 to August 2020. Consent was taken from consider each patient willing for the study, and the patients are evaluated clinically and radiologically at the time of presentation. The fractures are classified by using NICE classification. Here, the 2-part, 3-part, and 4-part proximal humerus fractures are considered for the study. Here in this picture, we can see the first column is minimally displaced or undisplaced fracture. And here the displacement means more than 1 centimeter separation, more than 45-degree angulation. Here we consider 4 components: lesser tubercle, greater tubercle, head, and the shaft. Any one of the component is separated, that is 2-part. 2 components are separated, 3-part, and all are separated, that is 4-part fracture. The inclusion criteria: patient age more than 18 years and 2, 3, and 4-part fractures, are willing to follow for a minimum of 6 months, and consent to be taken in the study, and the patient with the failure of conservative management also included in the study. Exclusion criteria: open fractures, past history of shoulder surgery associated with the neurovascular deficit, or patient lost to follow-up, and the pathological fracture due to the metastasis. Here the passive and assisted active range of motion were advised at 4th weeks, and at 6 weeks active range of movements are encouraged, and the patients were followed at a regular interval of 6 weeks, 12 weeks, and 6 months in the post-operative time. During each visit, patients are evaluated using constant modulus scoring. In this is a constant modulus scoring, and the components are: one is pain, the functional assessment and the range of motion and the strength. The total and the score, if it is less than 70 points, failure, 72 79 points unsatisfactory, 82 89 points satisfactory, and 92 and more than 90 points is excellent. Here it is a 4-part fracture. This is first one is pre-op image, and the second is after procedure. It is fixed with the Philos plate. This is the approach to the proximal humerus, that is a deltopectoral approach. We can see the main vein comes in the approach is cephalic vein. We should retract laterally to avoid injury to the vein. This is intro pictures. The first picture is draping, and second is the deltopectoral approach. And after plating the putting the plate and the lateral to the short end of the biceps, and this last one is the our CM image. It's a 3-part fracture, and this next is the post-op X-ray result. Age distribution. We can see in this graph, majority of the patient comes in 46 to 60 years of age, around 14 patients in our study, and 26 to 45 years age, around 10 patients, and 18 to 25 years, 2 patients, and more than 60 years, 6 patients. Gender distribution of the study, more commonly in the males, around 90 patients, and females, around 11 patients. Mode of injury among the study participants, we can see the majority of fractures are seen in the young patient because of the RTH, around 21 patients, and the slip and fall only 7 patients, and the fall from my 2 patients. The laterality of fracture among the study participants, right side 21 patients, and the left side is 9 patients. And the knees classification of fracture among the participants, 4 patient has 2-part fracture, and 15 patient has 3-part fracture, and 11 patient has 4-part fractures. This is the constant Muller scoring. The total score is 86.447, mean standard deviation. And the functional outcome of outcome grading by constant Muller scoring. 8 patients shows excellent outcome, and 19 patients shows satisfactory outcome, and 3 patients show unsatisfactory outcome. Functional outcome with the age of the study subject. We can see in less than 40 years of age, 2 patients shows excellent outcome, 9 patients shows satisfactory outcome, and 1 patient shows unsatisfactory outcome. In the age more than 40 years, 6 patients shows excellent outcome, and 10 patients shows satisfactory, and 2 patients show unsatisfactory outcome. Functional outcome with the gender of the study. In the male, we can see 8 patients shows excellent outcome, 10 patients shows satisfactory, and 1 patient shows unsatisfactory. The female, 9 patients shows satisfactory, and 2 patients shows unsatisfactory outcome. This is a functional outcome with the NICE classification. Here in the first graph, 2-part fracture, 2 patients shows excellent, and 2 patients shows satisfactory outcome. In the 3-part fracture, 2 patients show satisfactory, and 11 patients shows unsatisfactory, and 2 patients show 11 patients satisfactory, and 2 patients are unsatisfactory. In the 4-part fractures, 4 patients shows excellent, and 6 patients are satisfactory, and 1 patient is unsatisfactory. Because we can see in the 4-part fracture, usually the outcome is less, but here we can see because the majority of the fracture in the young age group. Philos plate gives a reliable fixation for a 2-part and 3-part fracture. Fixation of philos associated with satisfactory functional outcome. In case of complex 4-part fracture dyslexia where anatomical reduction is difficult, CT scan is required preoperatively. The discussion treatment of complex 3-part and 4-part fracture is challenging for the orthopedician. Surgeon must obtain an anatomical reduction and stable fixation, and at the same time minimize the iatrogenic risk of scoop penetration or avascular nephrosis of human head by the maximal protection of periarticular soft tissue. Poor results are seen in the complex fracture due to the inadequate fracture fixation, unstable fixation, and incorrect position of the plate. This is a reference. We can see. Thank you, sir.
Okay.
There are no questions in the chat box.
Yeah, we don't find any.
So I have one question. Just since you have mentioned that the comminution on the in the medial side is a risk factor for poor outcome, how did you address it in your series?
Yes, sir. Hello.
Hello, yeah.
Yes, sir.
How did you address the
The
medial
medial.
cortex comminution in your series?
Sir, if it is complex fracture, we should ask preoperative CT scan, sir, to know the preoperative status of the
Yeah,
fracture.
preoperatively by CT scan, you have found that there is a lot of comminution on the medial side. So how will you proceed? How will you address with this splitting?
Sir, we are putting the calcar screw to prevent the
Okay, the calcar screw for prevention of the collapse, varus collapse. Okay, any other tricks?
Okay.
No.
I think he has no answer for that. Probably, which type of plate you used? The Indian plate or it's imported one?
Indian plate, sir.
All even type 4 also.
Yes, sir.
Okay. Any other question? What was the aim of your study here?
Sir, the outcome of functional outcomes, sir.
Functional outcome, as Dr. Janardhan Aital also knows, it will be good in whatever the way you feel. Anyway, we'll move on to the next. Thank you for the paper, and we'll go on to the next one.
I think, sir, the next session is at 2:30. I think, sir, we have finished our this 1:30 to 2:30 section. We have completed.
No, we can.
No, we will go ahead. We will
go ahead. We'll continue with the next session.
Yeah.
We can start 2:30 session.
Yes, definitely. It's already 2:15.
Yeah.
We have.
Continue with the next speaker.
Yeah, we'll call with the next speaker.
Speakers are ready, no? Speakers are ready.
Yes, they are ready.
Yeah. Speakers are there. I think it's pre-recorded, no? So the next paper is: does clavicular shortening affect the shoulder function after treatment of mid-shaft clavicular fractures? A functional and analytical study. Looks good here. Dr. Mukesh Ram, ready? He's also there, no? The speaker is around.
Speaker is there. Supriya, we can start.
Sure, sir. One moment.
So we have time for question and answer, Dr. Janardhan.
Correct.
In future,
minutes we have saved, so we can use it.
So we can use it here.
We have time till 3:20.
Yeah.
This session.
No problem.
Yeah.
We'll utilize that.
Good afternoon. Type of fixation for acromioclavicular joint dislocation. Introduction. Acromioclavicular joint dislocation is common injury of shoulder related to sports. The contact athletes represent the high-risk individual, especially those who play sports like football, rugby, and hockey. But this type of injury is also seen in road traffic accidents and industrial accidents. One of the most common mechanism is falling or being tackled.
Presentation is: does clavicular shortening affect the shoulder function after treatment of mid-shaft clavicular fracture? A functional and analytical study. The aim is to assess the impact of clavicular shortening in mid-shaft clavicular fracture treated by non-operative method and by elastic nailing, 25 cases each. This is a prospective study of mid-shaft clavicle fracture. 50 patients met the criteria. Study done in Government Kilpauk Medical College Hospital from Jan 2016 to Jan 2020. Age of 20 to 55 years were included in the study. Mid-shaft fracture shortening with displacement of more than 20 millimeters. Threat of skin penetration associated with rib fractures, bilateral clavicular fractures. No other fractures of upper limb were included in the study. Male of 37 cases and female 13 cases. Predominantly right side Robinson type B1 classification was considered. Nail size of 2 to
Audio issue is there. Can you set it right? Audio is not there.
This oral presentation is: does clavicular shortening affect the shoulder function after treatment of mid-shaft clavicular fracture? A functional and analytical study. The aim is to assess the impact of clavicular shortening in mid-shaft clavicular fracture treated by non-operative method and by elastic nailing, 25 cases each. This is a prospective study of mid-shaft clavicle fracture. 50 patient met the criteria. Study done in Government Kilpauk Medical College Hospital from Jan 2016 to Jan 2020. Age of 20 to 55 years were included in the study. Mid-shaft fracture, shortening with displacement of more than 20 millimeters. Threat of skin penetration associated with rib fractures, bilateral clavicular fractures. No other fractures of upper limb were included in the study. Male of 37 cases and female 13 cases, predominantly right side. Robinson type B1 classification was considered. Nail size of 2 to 3 mm was used. Conservative method, there are two methods available, but I prefer to use a sitting technique with hands over the hip and shoulder brace, and figure of 8 bandage is applied and arm supported with a sling. Figure of 8 bandage is maintained up to 3 to 4 weeks. This is a case of non-operative method where he had restriction of shoulder movement, and this patient had a malunited clavicle. In operative method, elastic healing was done under general anesthesia. Small skin incision made in the medial end of the clavicle. Appropriate nail, elastic nail was entered through the medial end, negotiating the fracture site at the center to the lateral end, confirmed to the image intensifier. I had problem in 6 cases where the close reduction could not be done, so a small incision was made over the fracture site. A nail was advanced into the lateral fragment. There was no any complication encountered. The arm was supported in a sling. X-ray taken on the second POD and gentle pendulum exercises allowed. Sling discontinued on third week. Unrestricted range of movement exercises were allowed, but no strengthening resisted exercise hard work was allowed. Periodic X-rays were done on 4th, 8th, and 12th week to evaluate the bony union. If acceptable, the patient was allowed to begin resisted and strengthening activities. In one case of delayed union, the activities are avoided until 14th week, but all cases had good radiological union. Elastic nailing had a good functional results, and this is a bilateral clavicle fracture in a female, operated in 2 separate sittings. This is another female, and we had few complications on operative method: non-union, malunion, and deformity. And the main problem of elastic nailing was prominence of the elastic nail. Evaluation: various outcome measures were used to evaluate the shoulder function and the follow-up. The data set for each patient included a difference in the length of the clavicle measured from the jugular groove to the lateral border of acromion. Clavicular shortening being defined as difference between the affected and unaffected side. Subjective assessment based on visual analog score, range of motion, and constant moldage score, dash score, and colonies clavicle scores. All are based upon their subjective and objective variable. The Norquist criteria was not taken into account. The dash, constant, CC score were the primary outcome variables. Range of motion was calculated as the difference in the degrees between the injured and uninjured side. Analysis of the study: clavicular shortening, average shortening was 1.2 plus or minus 0.95 centimeters. Non-operative, there was more shortening. And operative, there was shortening of less than 1 centimeter in 4 cases. Pain: 45 cases had pain-free movement of shoulder. 5 cases had restricted movement. Of those, 2 were diabetic. In elastic nailing, scores better range of motion than the non-operative method. VAS score also shows that the elastic nailing scores better result. In manual muscle strength of static and dynamic contractions, we had no correlation was found between the decrease in strength and radiographic appearance, and there's no statistical difference between the radiographic malunion and strength difference between the shoulders. Constant Muller scores, cash scores, colony clavicle scores also scores better in operative method. Results: the mean duration of follow-up of the entire study was 28 plus or minus 15 months. Patient with shortening of more than 2 centimeters was noted in non-operative method, whereas operative method is less than 1 centimeter. Analysis of result of elastic nailing conservative method: all the cases related well in anatomical positions in elastic nailing, and excellent outcome was noticed in 21 cases in elastic nailing, and had few complications as showed in previous pictures. Discussion: from biomechanical point of view, the clavicle holds the glenohumeral joint lateral to the trunk. Although shoulder EMS symmetry after clavicle fracture is a complex three-dimensional problem, in symptomatic patients, shortening of medial lateral length is frequently the most characteristic finding. There is an increasing evidence that patient can have substantial dissatisfaction following clavicular malunion because of symptoms like pain, weakness, and easy fatigability. There is various studies to support that the shortening affect the shoulder function. By McKay, Chan, and Bosch, they noticed the shortening in the clavicle affect the shoulder function. In an experimental study, biomechanical setting, it has been demonstrated that clavicular shortening has a significant planar malposition. In cadaveric study, it was found that the shortening of clavicle of more than 10% affect the kinematics of the shoulder girdle and could produce clinical symptoms. And McKay, he assessed based on the dash and constant Malay score of 30 patients of 55 months duration, and he noticed that a shortening of more than 2 centimeters associated with a greater 10 towards patient dissatisfaction. Our study was able to be compared with other studies. This study presented here indicates that the clavicular shortening greater than 1 centimeter is associated with significantly inferior scores compared with healthy individuals. The strength of this study includes the duration of follow-up and use of both patient-oriented and objective outcome measures. To conclude, operative treatment leads to improved short-term outcomes, increased patient satisfaction, early return to activity, lower rate of non-union compared with conservative treatment. Yes, definitely the shoulder functions are affected after treatment of mid-shaft clavicular fractures. However, operative treatment associated with increased risk of complications, reoperation, while long-term shoulder functions are similar. Thank you.
Okay. Any questions we do see here? No question.
No questions in chat box. So one question from my side, Dr. Mukesh. Since you have divided these patients into two groups, okay, what is the basis of deciding on which patient will go to conservative and which patient will go
same question I had. Yes. On what basis did you patient selection, operative and non-operative?
You have to unmute yourself. No, voice is not audible. Your voice is...
No, you are not unmuted, I think.
Maybe the issue with the speaker, I think.
Use your computer speaker rather than a headset.
Correct. No, it is not audible. I think you can remove the headset and use the computer speaker.
Use a computer speaker rather than using a headset. Hello?
Hello, is it audible?
Yeah, now it is audible.
Yeah.
Okay, so it was designed based on lot basis.
So
based
you
on lots for 50 cases, 25 each of conservative and 25 each of elastic nailing. So based upon lot basis, whichever the patient was accepted to proceed for the study, they were chosen based on lot basis.
So sometimes the patient consent also plays a role. Like even if the lot, through the lot, you would have got the patient in surgical group. Suppose if the patient had not consented.
The patient who were willing for the study, they were considered for this study.
Okay.
And they were decided based on lot basis, whether I'm choosing for a conservative or for a surgery, elastic nailing.
Okay. Well, have you done any variable analysis to see the fracture pattern and other things, whether they are similar or?
Yeah, there were some dissimilar cases. So in the clavicle, the fracture which was very close to the S-bend, I had difficulty in negotiating the fracture fragment because on that area the canal diameter was quite small. So those were the areas where I had difficulty in negotiating the lateral fragment. In other ways, it was very easy. So I took average of 22 minutes to finish off closed elastic nailing of and even for a maximum of 1.5 hours where I had difficulty in negotiating the elastic nailing through the lateral fragment. So my observation was that when the fracture is at the before that S-bend, it was very easy, or at the level of S-bend or just medial to S-bend, definitely that was very difficult.
Okay, so my question was about patient characteristics, whether the two groups that you have selected were similar in all aspects, like their diabetic status, their fracture pattern and other things, the variables.
Yeah, all are similar, sir. All are similar. But I had problem in 5 cases where the shoulder, the patient had persistent pain. And on further evaluation, we noticed that the 2 patients were diabetic and they were uncontrolled. So they had restricted shoulder movement. So attributing to the treatment and for the diabetes, it was coincidental.
Okay, this study was done in a government hospital, you said?
Yes, sir.
The implant is provided by the hospital, or did the patient have to buy for?
All the implants are available, sir. All the implants are available.
So that is why you had the luxury of trying this very disputable topic of fixing the middle shaft fracture of the clavicle. Anyway, you had even, you said how many complications you had in operated cases?
Operated cases, I had a problem in 3 cases, sir. Only the medial prominence, no infection was noticed and no other problem. Only the medial migration was noticed in 2 cases. So that patient, I was supposed to remove the nail early.
So that is very dangerous, isn't it? The medial migration is innocuous. It is dreaded.
Medial migration means since we are making the incision only in the anterior cortex, it's not migrating through the jugular in between the interclavicular groove. So it migrates
come to the skin,
anterior through the skin.
So another question is like, have you analyzed or compared dash scores between those patients who had more than 2 centimeter shortening and less than 2 centimeter shortening?
Yes, sir. Yes, sir. It was there. It was observed. The dash score was observed for all the patients.
So what was the difference between these two groups? Those who had less than 2 centimeter shortening and more than 2 centimeter shortening.
Yeah, definitely the 2 centimeter shortening, the patient had a restricted amount of movement and all the subjective and objective variables were compared between conservative and this elastic nailing. Definitely the 2 centimeter difference goes better in elastic nailing.
Okay.
So patients were counseled before selection, you mean to say?
Definitely.
They were given option of both the treatment?
Yes, sir. Definitely, sir. All the patients were counseled regarding for the conservative and elastic nailing, because already it was chosen based on lot basis and patient was explained, all this protocol, everything has been explained in detail. If the patient is willing for this study, they were taken for the study.
The
and the
union
consent was also obtained. Yeah.
union time was almost same between operative and non-operative, isn't it?
Yes, sir. Exactly. Union time almost 12 to 16 weeks.
There is no significant difference.
Yeah.
Only thing is you're only looking into the shortening.
Yes, sir. Exactly.
But the big question here is how much of functional deficit you have with the shortening, what you mentioned, that is less than 1 centimeter of shortening you
Yes,
showed
sir.
us.
Yes, sir. Yes, sir.
So would it account for such functional disability?
Yeah, that is what has been mentioned, because only for the patient satisfaction, because they had some pain, some restricted muscle strength, everything has been tested. And for the patient satisfaction, I am not telling that conservative is not good as elastic nailing, but this is a biomechanical study to assess the length of the clavicle. Does the shortening makes any difference of the shoulder function? So definitely the elastic nailing scores better over the conservative treatment.
In reducing the shortening, you mean?
Yes,
no,
exactly.
no other parameter it has helped.
Exactly, because elastic nailing by 3 weeks, almost by 3 weeks, I remove the sling. But in case of conservative treatment, which are in 25 cases, until there is some amount of newborn formation at the fracture site, I cannot remove the sling. Otherwise, it will go for non-union. So initial cases, it was observed, I encountered 2 to 3 cases of non-union and 2-3 cases of malunion.
Anyway, that is again disputable. The recent thinking about conservative management is just 2 weeks of immobilization, sling, nothing else. It unites whichever the way, whether patient lifts up or downs. There is no conclusive evidence of strapping, sling, or any of the braces for non-operative method. Okay, we can move on to the next paper. I think if we are finished, or any question left?
No questions in the chat box. So we'll go to the next topic.
Yeah. So the next one is tightrope fixation for acromoclavicular joint dislocation. Dr. Raj Guhan.
Sir, good afternoon. I'm here, sir.
Yeah. It can be started.
Good afternoon. Tightrope fixation for acromoclavicular joint dislocation. Introduction. Acromoclavicular joint dislocation is common injury of shoulder related to sports. The contact athletes represent the high-risk individual, especially those who play sports like football, rugby, and hockey. But this type of injury is also seen in road traffic accidents and industrial accidents. One of the most common mechanism is falling or being tackled onto the lateral aspect of the shoulder with the arm in an adducted position, which produces compressive and shear force across the joint. The injury force which drives the acromion medially and downward produces a progressive injury pattern. First, disruption of the acromioclavicular ligament, followed by coracoclavicular ligament, and finally, disruption of fascia overlying the clavicle that connects the deltoid and trapezial muscle attachments. This classified into 6 types, depending on the damage to acromioclavicular ligament and coracoclavicular ligament. Surgical treatment is commonly applied for more than type 3 injury of Rockwood classification. There is some controversy regarding the type 3 injury, but surgical treatment is accepted for young patients, athletes, physical labor, and for cosmetic purposes. This is a picture showing 6 types of Rockwood classification. And the use of metal implants can be complicated by displacement of these implants. The hook plate is effective for fixation of grade 3 and more. However, it can cause disturbances over the subacromial bursa, supraspinatus tendinitis, disturbances over the plate in acromial osteolysis, and migration of plate. There is a need to remove the hook plate after healing to prevent potential irritation of the acromion or impeachment of the rotator cuff. Tightrope apply a non-rigid fixation of the AC joint that maintains reduction, allowing for normal movement of the joint. They withstand cyclic loading without cutting out from the bone, and there is no need for removal of implant. This is the picture showing hook plate fixation and tightrope fixation. To details the methods, total 10 patients with acute acromioclavicular joint dislocations were followed for in this study from 2017 January to August 19. Of 10 patients, 6 patients had type 3 injury and 4 patients had type 4 injury according to Rockwood classification. The study included 8 male patients and 2 female patients aged 26 to 49 with an average of 37.5 years. In all 10 patients, 6 had road traffic accidents and 4 had slip and fall. Right side injury was present in 7 patients and 3 had left side injury. Inclusion criteria: adults with acute, closed, and higher than Rockwood type 2 of AC joint dislocation, fixation with tightrope, normal shoulder function before injury, without associated injuries, and follow up in one year. Exclusion criteria were fracture of clavicle or acromion, open injuries, chronic dislocations, ipsilateral injury in same upper extremity were excluded. So, preoperatively, anteroposterior and scapular YV radiographs were taken for all patients to assess the severity of dislocation and associated fractures. All 10 patients underwent open reduction and stabilization with tightrope system and were augmented with KYS for a period of 6 weeks. This is the picture showing AP view and scapular Y view. And procedure done under general anesthesia, patient was placed in supine position. A vertical skin incision was made over the acromioclavicular joint and coracoid clauses. After dissection of subcutaneous tissue, deltoid is cut off the clavicle subperiosteally, allowing visualization of coracoid clauses. The base of the coracoid was then exposed and identified well. A 2.5 mm drill bit was positioned on the superior aspect of the clavicle directly over the coracoid to drill down the 4 cortices of the clavicle and the coracoid, center on both as possible to achieve strongest fixation and avoid coracoid heterogenic fracture. The guide wire attached to the fiber wire suture of tightrope is passed through the clavicle and then the coracoid and retrieved below the coracoid. One button is placed over the undersurface of coracoid clauses and the other button lay flat on the superior surface of the clavicle. After manual reduction of AC joint, we maintain reduction until fixing the tightrope by K-wire to lateral side of acromion to distal clavicle. After fixing the tightrope, skin sutures and aseptic dressing was done. Post-operatively, broad-arm sling was given for a period of 6 weeks. Gentle pendulum exercises were encouraged post-operatively. However, active forward flexion and abduction over 90 degree were limited to prevent K-wave breakage until K-wave removal after 6 weeks of surgery. From 7th week, a free motion was allowed. The sports activities were not allowed for a period of 3 months. All our patients were taken radiographs post-operatively after 6 months and also after 1 year after surgery and were followed up clinically. The radiographs were evaluated for acromion osteolysis and presence of post-traumatic osteoarthritis, which may or not accompanied by clinical symptom. Clinical outcomes were assessed using University of California Los Angeles score, which analyzes pain, function, active forward flexion, strength, and satisfaction. Furthermore, we performed cross-body adduction tests to check clinical relevance to acromioclavicular joint osteoarthritis in all patients. Results: the study included 10 patients, and all 10 patients were admitted for operation within 1 week of onset of injury with a mean delay of 2.3 days. All cases done did not undergo any reoperative procedures. With regard to clinical outcome at the final follow-up, the mean score of UCLA was 30.8. 3 patients had excellent results and 7 patients had good results according to UCLA score. 1 patient had pain at the acromioclavicular joint for 4 months post-operatively, but the X-ray showed no evidence of acromioclavicular joint osteoarthritis in 1 year follow-up, and the rest had no complication like redislocation, infection, or rupture of tightrope. Mean range of movements at final visit in forward flexion and abduction revealed 170 degree and 160 degree. No patient had aggravation of pain on cross-body adduction test, which showed no patient developed acromioclavicular joint arthritis. So there are 10 patients. And the discussion in tightrope technique, there is no need to remove the implant. In addition, surgical reduction in tightrope could maintain the acromioclavicular joint reduction during the initial period and thereby enabling biological healing by working as an internal brace that keeps the joint reduced during the necessary healing time. Tightrope technique allows visualization of the achieved reduction, which could explain the low complication rate. Tightrope fixations resulted in good outcome, good shoulder function, and normal quality of life. Other methods like hook plate provide a non-rigid fixation and good results, but it may cause rotator cuff injury, subacromial impingement, and acromial fracture. In tightrope was developed for reduction of vertical instability and maintenance of coracoclavicular distance. Due to the advantage of stable fixation power and needlessness of removal procedure, it was introduced. All cases of tightrope are augmented with KOA fixation to provide better AP reduction of ace joint dislocation. 2 KVAs are left for a period of 6 weeks to provide a better fixation and to allow a better healing and scarring of the STL ligaments. Until KOA removal, there were no KOA-related complications such as metal breakage or neurovascular damage by migration. This is a case when showing the pre-op X-ray of ace joint dislocation and post-op X-ray showing tightrope fixation and augmented with KOAs. And this is the post-op X-ray at 1 year follow-up. And this is the clinical outcome at 1 year showing good range of movements, abduction, adduction, internal rotation, external rotation, and extension. And this is the case 2 showing pre-op X-ray of ace joint dislocation and post-op X-ray showing fixation with the help of tightrope and 2 KOAs. And this is the post-op X-ray at 1 year. And this is the clinical outcome at the 1 year with good range of movements. And conclusion, open reduction and stabilization of tightrope in type 3 dislocation and above are effective techniques regarding the objective outcome scores. Tightrope fixation provides a low rate of failure and complications and avoids the need for second surgery to remove the implant. So the references for my studies. Thank you.
Okay. Fine then. No questions from the audience. Janardhan,
questions,
you will be having question because Canada Orthopedic Society discussed the same thing, isn't it? So, Janardhan,
So have you made any attempt to repair the coracoclavicular ligaments?
Actually, in some patients, we try to repair it.
No, all your patients are type 3, isn't it?
No, sir.
type 4 also.
We had type 4 also, sir.
Type 4
type
also.
3 and type 4, sir.
Type 3. What is the patient profile in type 3 injuries?
Mode of presentation, sir.
No, patient profile in the sense how active
patients in the type 3 mainly complaint of sir, they mainly complaint of pain at the ace joints at the site of dislocation.
No, I just want to know the patient profile means how active they are, what is their occupation, what is their demands.
So in type 3, most of the patients were below 40 years of age, sir, and some of them were manual laborers, sir. Okay. And other 2-3 patients were professionals only, sir. But since they were advised regarding the persistence of pain for a long time, if it is treated by conservative management, they opted for surgery, sir.
So what was the time lag between the injury and the surgery?
Yes, sir, they are all 10 patients had a mean delay of 2.3 days, sir. They were all 10 patients were done within 1 week of injury, sir. Some had like 4 or 5 days, but mean was 2.3 days, sir. Some of them did undergo surgery at 2 to 3 days.
Okay. What you used fiber wire for all the cases, no?
Yes, sir. Arthrex tightrope.
Arthrex.
What was the gauge? Gauge of the fiber wire? They have 2. Hello.
Yes, sir. Yes, sir.
The gauge of the fiber wire. Thickness.
I'm not sure, sir.
Okay. Fine. Janardhan, you may have any questions? So all the cases were augmented with K wires.
Yes, sir. All 10 cases were augmented with 2 KVAs from lateral side of acromion to clavicle for a period of 6 weeks, sir, in order to provide anteroposterior stability also. And after 6 weeks, in all cases, the KVAs were removed, sir, and there were no complications related to it.
You could have put some operative pictures, 1 or 2 pictures of especially the holes you drilled from clavicle to the coracoid and
Yes.
And tightening of the fiber wire.
Correct.
Yes.
Okay. Okay. Janardhan, we will go ahead for the next.
Yes, I will go ahead with the next paper. The next paper is
Thank you,
on
sir.
evaluation of clinical results of single injection technique and peppered injection technique in lateral epicondylitis.
Dr. Vinay Ningappa.
Yeah, so you can start the presentation.
Good morning. I'm Dr. Vinay N from Kodagu Institute of Medical Sciences. I'm presenting paper on the topic single injection technique versus pepper injection technique in lateral epicondylitis. Introduction: tennis elbow lateral epicondylitis is a condition characterized by pain in the lateral region of the elbow at the origin of extensor muscles or the wrist and fingers. The condition affects 1 to 5% of the population, also known as tendinosis. It's the degeneration at the tendon attachment on lateral epicondyle and is caused by repetitive microtrauma. The term tennis elbow is actually a misnomer because the condition is commonly seen in non-tennis players. It may occur in patients performing any activity that involves repeated supination and pronation of the forearm with elbow in extension. The anatomic basis of the injury to the extensor carpi brevis origin appear to be multifaceted, involving hypovascular zones, eccentric tendon stresses, and a macrovascular degenerative response. Symptoms include pain over the lateral epicondyle, lateral side of the elbow, induced by gripping or resisted extension movement of the wrist. The choice of treatment for each individual case remains controversial and is based on the personal experience of the treating doctor. In peppering technique, multiple injections reach the bone through the regenerated tendons and connective tissue, causing local hematoma. It is believed that this bleeding may initiate a healing process. Corticosteroid injection, although widely used, conflicting evidence exists to support the use of steroid injection to treat lateral epicondylitis. Coming to the aim of the study, our aim of the study is to evaluate the clinical results of single injection technique and pepper injection technique in lateral epicondylitis. When coming to the methodology, study population includes patients presented to OPD or emergency services, was recruited for the study after fulfilling the selection criteria and was accordingly followed up. Sample size and method of calculation. Sample size includes minimum of 30 patients for each injection, that is single injection and pepper injection technique were included in the sample. Selection criteria, inclusion criteria includes adult patients of either sex more than 18 years, symptomatic lateral epicondylitis, patient with lateral epicondylitis not responding to ultrasonic or laser therapy. Exclusion criteria includes patients who had received more than 3 injections to the elbow in less than 6 months, history of trauma to the elbow, evidence of neurologic source of pain, infective pathology like tuberculosis, lytic pathology of elbow, and benign tumors of elbow. Randomization. The patient who fit into inclusion criteria were divided into 2 groups to receive 2 different mode of treatment. The technique adopted was block randomization. Come to the injection technique positioning. The patient was placed in a seated position with affected arm resting comfortably on the examination table. The elbow was flexed to approximately 90 degrees with the palm pronated so that it was flat on the table. This is the figure showing the injection technique. Coming to the Porter's injection technique, the point of maximum tenderness was identified with palpation and mark. The skin was prepared using betadine and alcohol. The injection of 1 ml of 10 mg per ml triamcinolone was mixed with 1 ml of 2% lidocaine. A 25 gauge needle was used for the injection. 3 injections was injected over a year of maximum tenderness at 2 weeks intervals. In single injection technique, it was performed by penetrating the skin at the identified area of maximum tenderness. The needle was advanced to the bone and slowly pulled back a few millimeters. The entire quantity of the syringe was deposited at this location and needle was then withdrawn. In pepper technique, it also began with penetration of the skin at the area of maximum tenderness. The needle was then advanced to the bone and then withdrawn a few millimeters. A small amount of steroid was delivered. The needle was withdrawn without removed from the skin and was moved back and forth approximately 30 to 40 times to form a hematoma around the epicondyle. Post-injection management, patient's area was cleaned with alcohol post-injection and sterile bandage was applied. Patients was instructed to use oral anti-inflammatory drugs and diets to control local discomfort from injection for 2 days. Patient was advised to avoid strenuous activity for 3 weeks and also asked to do strengthening exercises. Evaluation of the results. Evaluation was done prior to injection and at 3, 6, 12 months post-injection. Evaluation was based on tenderness grading, the visual analog pain scale, grip strength of both hands. Patient was patient was reviewed in a separate clinic by physiotherapist The physiotherapist measured the grip strength of both hands using a hand dynamometer. Measurements was made with the elbow fully extended and with it flexed to 90 degrees. The mean of two measurements will be recorded as the grip strength. Statistical analysis. The results will be statistically analyzed using chi-square test. Coming to the results. So this is a chart showing comparison of tendons at 12-month interval between two groups. So in single incision technique, out of 30, 2 had grade 1, 8 had grade 2, and 20 had no tenderness. That is around 66.7%. In pepper injection technique, out of 30, 1 had grade 1, 2 had grade 2, and 27 had no tenderness. So it almost comes to 90% compared to the single injection technique. So this is a chart showing comparison of visual analog score between two groups. So in single injection technique, okay, compared to pre-injection time and at 12 months in injection time, the visual analog score improved from 7.8 to 3.3 at the end of 12 months. So in peptide injection technique, visual analog score improved from 8.13 to 1.1 score. So there is significant improvement in the visual analog scoring. This is a chart showing comparison between affected and unaffected side at 3, 6, and 12 months interval. Okay. So in single injection technique, the grip strength of affected side was 23.1 initially, and grip strength of unaffected side was 38.7. At the end of 12 months, the grip strength improved from 23.2 to 31.2. In pepper technique, the grip strength initially it was 26.97 on affected side and 42.73 on unaffected side. So grip strength improved from 26.97 to 40.6 at the end of 12 months, and it was comparable to the unaffected side. Coming to the discussion, the most widely accepted theory is that lateral epicondylitis is caused by micro and macro twists in the tendon of external scapula radius brevis, and treatment has been directed at this. For elbow with single injection group, mean VS score decreased from 7.82 to 3.37, and for peptide injection group, visual analog score decreased from 8.1 to 1.1. There was significant improvement in both the groups. Both groups improved significantly over time, with more than 80% of subjects reporting improvements from baseline to 6 months. Tenderness, and comparing tenderness among both groups, p-value came out to be 0.017 at 3 months, 0.126 at 6 months, 0.145 at 12 months. In grip strength, in single injection group, at 3 months, it was 32.8 kg, at 6 months, it was 32.67 kg, and at 12 months, it was 31.2 kg. In pepper technique, at 3 months, it was 40.5 kg, at 6 months, it was 41.6 kg, and at 12 months post-injection, it was 40.6 kg. Conclusion, long-term clinical success in the treatment of lateral epicondylitis depends on the injection method. The peppering technique appears to be more effective than single injection technique in the long term. With this, I am concluding my presentation. Thank you.
Okay. Any questions from the audience? No.
No questions.
Yeah, did you face any adverse event or any complication in this peptide injection technique in those 1 year or 1.5 years of your study?
No, sir. I didn't have any.
And did you observe you have mixed steroids along with PRP in all the single technique as well as the pepper technique?
Oh, sorry, steroid and local anesthesia, lignocaine.
Yeah, so eventually it is a cocktail of steroid plus local anesthetic plus the PRP, right?
Yes, sir.
PRP, no PRP, no?
No PRP, so only
no PRP.
Only steroid.
Only steroid, sir.
Only steroid.
Yes, sir.
What is the time you take for this pepper type of technique? What's the duration of that procedure you take with each patient?
So it hardly takes 30 to 5 minutes, sir.
3 to 5 minutes, you could pull out 30 to 40 times and do that?
Sir, like 5 to 7 minutes you can do, sir.
I mean, my 35 years of experience, for single shot, even I am trying PRP. The patient wouldn't, tolerate. I am a little skeptical about this technique of repeated injections. Though you don't pull it out completely from the skin,
yes, sir.
Even little navigation inside that lateral epicondyle area induces a lot of pain, whether you give steroid or, whether you give local anesthetic or not.
Yes, sir.
So that question from Dr. Dikshit was, did you mix it all together with the steroid and give, or you gave the local anesthetic first and then did
No,
you
sir.
enter?
Mix in the syringe, sir.
Okay. Janardhan, you have a question.
No, sir.
No question?
No questions.
Anyway, according to you, this pepper technique has better result in terms of
Yes,
we are only worried, I think, in almost all lateral epicondylitis. I think Dr. Janardhan and Dikshit will agree that we are only worried about the pain relief than the strength of the forearm or wrist.
Exactly, sir. Yeah.
Yeah. So I think that should not matter much. Anyway, good paper. Thank you.
Yes, sir. Thank you.
Janardhan, you can announce.
Thank you, sir.
So the last paper for this session.
Last but
one.
one.
No. Sorry. Last but one. Yes. Just a minute. Yeah. Comparative study of surgical fixation techniques for displaced supracondylar humerus fractures in children between 3 and 8 years by Dr. George Shaji.
I'm not seeing anything in my computer here.
Who is it?
Greetings to all.
Dr. George Shaji, you are there?
Yes, sir. Good afternoon, sir. I am here. Firstly, I would like to thank the organizers of this conference for giving me this opportunity.
I think there are some audio issues.
Proceeding with my paper. A comparative study of surgical fixation techniques for displaced supracondylar humerus fracture in children between 3 and 8 years. Introduction. It is the most common fracture in the first decade. Displaced supracondylar fractures are known for difficulty in reduction and involvement of neurovascular structures. Although close reduction and percutaneous pinning is considered the appropriate management, there is still controversy regarding the ideal pin configuration. The aim of the study, to compare the functional and radiological outcome between two lateral pinning and cross pinning in the management of displaced supracondylar humerus fracture in children. Materials and methods. This was a prospective comparative study done at my institution. Total of 40 children with displaced supracondylar humerus fractures enrolled after an informed consent from their parents. A thorough clinical examination and neurovascular status was documented. AP and lateral radiographs were taken and classified using Gartlands. The injured elbow was immobilized in an above elbow splint. Close reduction and percutaneous pinning was performed using either of the techniques based on the operating surgeon's preference. Inclusion criteria. Age 3 to 8 years. Presentation within 72 hours of injury. Displaced but close fractures, Gartland type 2 and 3. No previous history of surgeries around the index elbow. Exclusion criteria, open fractures and late presentations, fractures associated with vascular compromise, coexisting fractures on the same limb, concomitant head injury and other life-threatening injuries. Coming to the surgical procedure, operation was performed by a senior orthopedic surgeon under general anesthesia, IV antibiotics administered as per institutional protocol. With the patient supine, the injured limb was placed on a small arm table. Close reduction was done under fluoroscopy guidance. Once an anatomic reduction was achieved, further stabilization was done by percutaneous pinning using either of the two techniques. The first one, the lateral pinning technique. 2 pins inserted from the lateral aspect of elbow with the elbow in hyperflexion. Bicortical fixation and good pin spread on AP are essential for fracture stability. The next technique, cross pinning. First, the lateral pin was inserted, keeping the elbow in hyperflexion. Now, with the elbow extended to less than 90 degrees, the ulnar nerve was rolled back with the opposite thumb, and the medial pin was inserted to engage the lateral cortex. Again, bicortical fixation and good pin spread are essential for fracture stability. After pinning, vascularity of the distal limb checked, stability of the reduction assessed, carrying angle compared with that of the unaffected side, ends of the pins were bent and cut off, limb immobilized in a long arm posterior slab with forearm in neutral and elbow flexed less than 90 degrees. Postoperatively, radiograph was taken to determine the reduction. Operated limb was monitored at regular intervals for neurovascular deficit. Uneventful postoperative period resulted in discharge. Parents were advised to remain watchful at home. At first follow-up, 4 weeks, radiological evaluation was performed to assess the maintenance of reduction. Pins were removed and clinical assessment done and graded as per Flynn's criteria, which took into account the range of motion at the elbow, the loss of the carrying angle, and we graded from poor, fair, good to excellent outcome. Subsequent follow-ups were done at 6th week and 3rd month and outcomes graded using Flynn criteria. Statistical analysis by Fisher exact test and unpaired t-test. P-value of less than 0.005% was considered significant. Coming to the results, males were commonly affected. Left side was often involved. Posterior displacement was more common, 40%. Pinning techniques were shared across both the study groups. If you see the graph on the right, the posterior lateral and posterior medial displacements often ended up with cross pinning. The clinical assessment by Flynn criteria at 4 weeks, 6 weeks, and 3rd month showed improvement, as you can see in the graphs, in the clinical outcome for both the groups. P-value at all 3 follow-ups was statistically insignificant. Radiological assessment by Bowman's angle at 4 weeks, 6 weeks, and 3rd month showed improvement in the outcomes in both the groups. Again, P-value at all 3 follow-ups were statistically insignificant. Complications: 1 patient in the cross-pinning group developed ulnar nerve neuropraxia that resolved at 1 month. 3 patients developed pin tract infection which subsided with antibiotics and dressings. No other complications were observed. Now coming to the case reports. The first case is a right supracondylar humerus fracture with posterior displacement, underwent cross-pinning. Below are the preoperative and postoperative radiographs. At 3 months of follow-up, good clinical outcome and radiographical outcomes were noted. The second case, a case of left supracondylar fracture with posterior medial displacement, underwent lateral pinning. Below are the preoperative and postoperative radiographs. At 3rd month of follow-up, there was good to excellent clinical and radiographical outcomes. Moving on to discussion. Close reduction and percutaneous pinning is considered the appropriate management in displaced supracondylar humerus fractures. The achievement of treatment is determined by good reduction, conservation of the reduction, and absence of complications until fracture union with good motion, flexibility, and cosmetic outcomes. The advantage of cross-pinning is that increased biomechanical stability, although iatrogenic ulnar nerve injury may occur. The advantage of lateral pinning is the avoidance of iatrogenic ulnar nerve injury, although the construct may have less torsional stability. However, studies have shown that both these techniques are equally effective in the treatment of displaced supracondylar humeral fractures. To summarize, males were commonly affected and the left side was most often involved. Most common displacement, posterior. Clinical and radiographical outcomes were comparable between the 2 groups. Average carrying angle loss was also comparable. 1 patient in cross-pinning group developed ulnar nerve neuropraxia that resolved at 1 month follow-up. To conclude, this study concludes that there is no significant difference with regards to the clinical and radiological outcomes achieved with lateral pinning and cross-pinning technique in the treatment of displaced supracondylar humerus fracture in children. These are my references. Thank you all for your patient listening.
Okay. Any
There are no
questions?
questions.
No
There are no
questions. Yeah.
So
how did you into group? How did you decide to which group the patient belongs to, lateral pinning or cross?
So it was decided based on the operating surgeon's preference.
That biased. The surgeon may be biased that I'm good at cross.
So actually with posterior lateral and posterior medial displacement, we had a total of 24 patients. 13 patients ended up in the cross pinning group and 11 ended up in the lateral pinning.
No, did you decide the cross pinning, that is also adding the medial pin, depending on the fracture pattern, or it was randomly chosen?
Yes, sir. That was depending on the fracture pattern, but it was at the discretion of the operating surgeon, sir. The
So
senior.
what pattern, now generally what pattern is preferable for cross pinning, that medial support also?
Yes, sir. The medial support generally when there was a rotational malalignment in case of posterior medial or posterior lateral, and after the lateral pinning, when we check the on AP view, the Bowman angle and the lateral view when we assessed for the angles, and clinically when we saw for the stability, when the stability was not good enough, the both the column fixation, the adequate length of both the columns, and if the column stability was not good enough, we ended up putting the medial cross pin, sir.
That
But
is
it was,
you. That means you decided on the table to put
yes sir,
the
it was
second
on
pin
the, yes sir, it was operating surgeon's discretion, sir.
on depending on the stability of the
Stability,
fixation.
yes sir.
So,
On
so I
the,
think continuing the discussion, in that time itself, you had not decided that the medial pin is better than the two pins from the lateral side. So probably it may not be a good idea to compare the functional outcome and say that both are equally good. Because by design of your study itself, you have admitted that the medial pin allows better stability of the fracture fixation.
yes sir, but we have also for the post, we have, there are patients, 11 patients with the posterior medial and posterior lateral ended up with lateral pinning, sir.
No, that is fine. When the lateral pins provided good stability, you are not gone for the medial pinning. But if the stability was compromised, you went for the medial pinning. So that was the issue. And second thing is the functional outcome also depends upon the quality of reduction rather than the type of pin configuration. So you should have addressed that in your comparison of the outcomes. Probably you could have selected different outcome parameters to say the cross pinning is better than the lateral side pinning.
Okay, sir.
Yeah, I think there are. This is a very controversial topic. If there is any pediatric orthopedic surgeon in the audience, they will have a lot of questions to you because it's very debatable of configuration and number of pins what you put on the side.
Yes
There
sir,
is
yes
a
sir.
lot of discussion going on and a lot of counter discussion also for the proponents and opponents. Okay, anyway, I think we have only one paper left, that is deformity correction in cubitus virus, our experience by Dr. Utkarsh Pradhan.
Thank you,
Dr.
sir.
Jar, thank you. You can
Thank you, sir.
switch off your camera. So whatever the previous speaker had difficulty, they will correct in this.
Yeah.
Deformity correction in cubitus varus, our experience. Introduction. So the cubitus varus is, or a Gernstock deformity is of the elbow, is the one of the commonest complication of malunion after supracondylar fracture of the humerus in children. The normal carrying angle at the elbow between 3 to 7 degrees of, it's between 3 to 7 degrees of the valgus, is reversed into varus and resulting into an ugly deformity. Unfortunately, it does not improve with remodeling even in the younger children, and it is not in the plane of the normal movement. It is the sagittal plane. So we would like to share our experience in the surgical treatment of the cubitus varus. Now, what was the aim of our study? It was a study to study the radiological and functional outcome following the correction in cubitus varus deformity and to assess the outcome of commonly used osteotomies. Materials and methods. So we did a prospective study. The total number of patients in our study were 9. The mean age was 7. There were 6 boys and 3 girls in our study. Right side were 4 and the left side were 5. Now the mean duration of presentation to our OPD with deformity was 20 months from the date of the injury. The majority of cases, the majority of the cases, all the seven cases, they went indigenous treatment in the form of splinting, that are native splinting. In the 2 cases, the cubitus varus resulted from the failed growth reduction and K-wire fixation. The humeroulnar angle was measured in the anterior posterior radiograph in full extension and supination. The mean humeroulnar angle was measured to be 23 degrees of varus. Now, the amount of correction required was decided based on the carry angle of the normal side. There was no other restriction of movement other than the deformity in the coronal plane. There was mean internal rotation deformity of 10 degrees by comparing the arc of rotation of the ipsilateral shoulder with the contralateral shoulder. None of the selected patients for osteotomy had a distal neurological deficit, and none of them had a myositis ossificans. Now, coming to the treatment of this, all the patient, out of 9 patients, 7 cases underwent lateral closed wedge osteotomy, and 2 patients went reverse V osteotomy. Now, the base of the lateral wedge of the bone was measured through the X-ray, considering the magnification. The treatment was done with the K wires used with K wire, or either done with the plates, which was 3.5 mm T buttress plates in one patient and 3.5 mm reconstruction plate in another patient. So the 7 patients were treated with KYs. The other 2 patients, one was treated with T plate, 3.5 mm T buttress plate, and one was treated with 3.5 mm reconstruction plate. Now the patient in whom plates were used were 13 and 15-year-old. And as we know that the internal fixation rather than K-wire is preferred in the cases of older children. Now all the cases were operated under general anesthesia, they were intraoperatively positioned in the lateral position. Triceps splitting approach was used in all cases, and ulnar nerve was subcutaneously released for safety and better exposure. Now, after the surgery, above elbow slab was applied for 3 to 4 weeks. Now, in patient where K-wire was used for fixation, the wires were removed as an outpatient procedure at around 4 weeks. Active mobilization of the elbow was started. All the patients was followed up with the biplanar X-ray at 3, 6, and 12 weeks. Clinically, range of movements and the carrying angle was measured with the goniometer. The final carrying angle was assessed when full extension was obtained. Coming to the results and complication, the loss of reduction occurred in 2 cases, one from the K-wire group and one from the plate fixation group. Now, a 15-year-old girl who had undergone plate fixation with the posterolateral 3.5 mm reconstruction plate after reverse V osteotomy. At 6 weeks, what we noticed that there was a loss of correction and there was loosening of screws. Now, the patient was again advised for the surgery, but the patient refused for that. Another children who had undergone K-wire fixation when after lateral closed wedge osteotomy had a persistent whereas even after at follow-up also. Probably it was because of the loss of reduction or an inadequate intraoperative correction. So, and other 2 patients developed Z deformity with functional impairment due to lateral condyle prominence. Patient was dissatisfied with the outcome following Z deformity, even though radiologically and clinically the humeral angle appeared normal. But the patient and the parents were not satisfied. Coming to the discussion of our study, we all know that the correction of cubitus varus is usually undertaken for the cosmetic reasons only. So it should therefore be there should be no major complication, and it should produce consistent results. The varus osteotomy that have been described for cubitus varus, that they are mainly pentalateral osteotomy, medial opening wedge osteotomy with bone graft, oblique osteotomy, step cut osteotomy, and famous being the lateral closed wedging osteotomy held with screws and wire. Now, all of the method has their own pros and cons, and even there is the possibility of loss of correction in all of them. Now, the other complications which settles are most importantly are infection, loss of fixation, stiffness, heterogeneous palsy, brachial artery injury or aneurysm, lateral condyle prominence, which is the Z deformity. Now, as part of our study, we observed that the correction of hyperextension of the distal fragment is very important, because we also observed that it is very important for correcting the range of movement of the elbow. We also observed that the chances of implant failure in maintaining reduction is more when the profile of the bone is larger, as seen in the older patient aged 13 and 15 years in our study. So that is why the patient who are older age, 13 and 15 years old, internal fixation was done with the plate rather than K-wire. In spite of the correcting osteotomy for cubitus varus, the elbow sometimes gives a poor cosmetic appearance due to the bony prominence of the lateral condyle region. Although the carrying angle is corrected, it still gives a poor cosmetic result, and cosmetic being the very reason why we're doing this surgery. Now, the advantage of the reverse V osteotomy is that the lateral base of the V is close. The lateral edge of the triangle is medially translated and fits into the proximal apex of the triangle, and this very reason it prevents the Z deformity. Now, coming to the conclusion of our study, now the supracondylar corrective osteotomy for cubitus varus deformity, first of all, it's not a simple procedure as it is made out to be, and in a significant percentage of the patient, there is loss of correction. There are other complications also resulting in dissatisfied parent. So it is important that we very well plan all this surgery. The distal fragment must be medially translated so that we can reduce the lateral condyle prominence and we can reduce the Z deformity post-operatively, and also to prevent the loss of correction. Now coming to the cases, this is the very first case. We had a very good result in this case. It was a 4-year-old child with the supracondylar fracture malunion, cubitus varus. This was a preoperative X-ray. We did a lateral closed wedge osteotomy, following which K-wire fixation, and was the follow-up at 6 weeks. So you can see the deformity has been corrected, and patient was actually very satisfied. We also had some complication. This was one of the complication, which was the Z deformity, where radiographically the humeroulnar angle was corrected, but still it was Z deformity and patient was not satisfied. And this was the case which was treated with 3.5 mm T buttress plate, and there was a loss of correction and intraoperative only. So these were the complications. Thank you so much.
I don't see any questions again. What was the mean age in your study?
So it was 7 years old.
Huh?
It was 7 years. Sir.
7 years.
Yes, sir.
Okay, because you made one statement that correction of the hyperextension is more important. So how do you substantiate from your results? Because it is against our common belief that varus and rotation are most important components of this, which we need to address. So how you come to that conclusion? How many of your patients had hyperextension injury? How many of them had residual hyperextension, and you had problems with the range of movements?
So actually, we had 4 patients, sir, who had residual deformity, hyperextension deformity, sir.
Hyperextension.
Yes, sir.
Was it after the correction or before the correction itself there was a hyperextension deformity?
Before the correction, sir.
Okay. And you were able, did you correct it or?
We did correct it, sir.
Okay, so you have corrected it. So now then in that case, probably making a comment that hyperextension correction is more important. Otherwise, it will lead to loss of movements is not an appropriate statement. That's what I believe, because in 7 years, we expect some remodeling of the flexion hyperextension in that arc.
Yes, sir.
The varus and rotational component that may not remodel, and it may worsen. So unless you have 2 groups of patients where you are not corrected hyperextension and it really led to the loss of flexion movements, probably it may not be appropriate to make that statement.
Okay, sir.
So which patient did you select for reverse V osteotomy, and which are the other patients? How did you decide which one requires reverse V and the lateral wedge?
So actually, we went for only V osteotomy only, sir. Only for the older patient, we went for reverse V osteotomy and plate fixation, sir. For all the younger patients, we went for V osteotomy only, sir.
What is the reason?
Lateral wedge closed osteotomy.
What is the reason? Now, why did you not go for lateral wedge for younger patients? That is the common.
Sir, we went for lateral wedge osteotomy only, sir. Older patient, we went for reverse V, sir.
You are telling me opposite. So, the older the patient, you wanted reverse V.
Yes, sir.
Reverse, and still it did not improve cosmetic appearance. What you said?
Sir, out of 9 patients, in 5 patients we had good results, sir. But in 4 patients we had different complications, sir. Like in 2 patients, the reduction was lost. One in the K-wire group and one in the plate group, and 2 patients had Z deformity, sir.
In both the methods, you chose lateral approach only?
Yeah, tricep splitting approach, sir.
Lateral?
Yes, sir.
Any other questions? Again, plate and screw, how did you decide? Depending on the age or type of osteotomy?
We decided on the age of the patient only, sir. Younger patient, we went for K-wire fixation. For the older patients, we went for plate fixation. As the bone profile is bigger in older patients, K-wire would not be sufficient for fixation, sir. That's why.
It's not according to the osteotomy, type of osteotomy.
No, sir.
So how many you had complications?
So in 4 patients, we had complications, sir. One K-wire fixation group, he had a loss of reduction post-operatively. One girl, 13-year-old girl was there. We did reverse V osteotomy and plate reconstruction, plate fixation with the reconstruction plate. She had a loss of reduction at 6 weeks, sir. So we advised resurgery for that patient. She was not willing. Her parents were not willing for surgery. and 2 patients, young patients, are they like 7 years and 5 years old. They had radiologically it was corrected, the deformity was corrected, but clinically they were having Z deformity, sir. So the parents were not satisfied with it.
So by your expression, it means that reverse V had more loss of reduction than the conventional lateral wedge, because you had less number of reverse V osteotomy, isn't it?
Yes, sir. Yes, sir. And
How
we
many?
went for reverse V osteotomy in older children, sir. And in older children, the correction of the deformity, we found that it's more difficult rather than in younger children, sir.
So the complications were more there.
Yes, sir.
Okay. Anything else, Dr. Janardhan?
No.
If there are no questions,
So
can we wind up this?
yes. Thank you very much.
Yeah.
It was a very good session, very good presentation, and especially thank you, sir. Thank you, Dr. Janardhan, sir, and Purushottam, sir, for moderating this session. And we have a inauguration now at 3:30 p.m. in Hall A. Hope we'll join you there at the inauguration.
Okay.
Thank you so much.
Thank you.
Thank you. Thank you.
Thank you, sir.
Thank you.
Thank you, Janardhan. Bye.
Thank you.
Thank you.